This next group of drugs are the calcium channel blocking drugs. And essentially what we're going to do is we're going to reduce the influx of calcium inside of these neurons, and that's going to control or mitigate the production or the propagation of this focus or this arrhythmia. There's really two drugs that are calcium channel blockers. Ethosuximide blocks the T-type calcium channel, specifically in the thalamic neurons, similar to the supposed mechanism of valproic acid. There's a metabolic activity of ethosuximide where some of the metabolites are converted into inactive products. This drug tends to stick around for quite a long period of time. These inactive products also may have slow body clearance. You can see them being used for different types of seizures, absence seizures, as well as also known as petit mal seizures. The side effects are listed there. I don't know why these learning objectives keep getting put on there like that. Side effects can include GI irritation, nausea, vomiting, dizziness, as well as an insensitivity to light. Another drug that we'll talk about in a few other cases includes gabapentin. We think this affects sodium channels, a different type of sodium channel, specifically on the neuron, but it also may affect GABA as well. And in fact, you can tell by its name, it's an amino acid analog of GABA. It doesn't really affect the GABA receptor, but it seems to alter the release of GABA. Remember, GABA is one of the kind of inhibitory neurotransmitters. Gabapentin is also unique in that there's no metabolism, and so compared to all the other drugs that can be used for epilepsy, there's very few to no drug-drug interactions. The indications are listed there. You can see gabapentin's been used as an adjuvant for various types of seizures, also to control neuropathic pain, as well as fibromyalgia. Side effects can include up to ataxia, headache, tremor, and somnolence. So that was kind of a nice segue into drugs that affect GABA. And so to put this kind of in historical context, seizures for a long time used to be treated with phenobarbital. And so what medicinal chemistry did is it kind of changed the substitutions around this molecule, and if you took organic chemistry, even if you didn't like it, you can see how kind of this phenobarbital molecule could be turned into phenytoin. Phenobarbital is not often used because there's significant toxicity, and then from the patient's perspective, you can see profound sedation. And so we don't really use phenobarbital specifically for seizures anymore, but it does have clinical indications outside of that. And so there's still limited use for phenobarbital with seizures. They wouldn't be kind of your go-to drug for every type of seizure. Some of the phenobarbital derivatives have been used for anesthesia. Some of them have been used for sleep aids, although not necessarily in the US. And we also have used these derivatives for interrogations, lethal injections to produce medically induced coma, as a truth serum. We put down animals routinely with derivatives of phenobarbital. So there's lots of medicinal uses, and we'll talk about this drug in more detail in a couple weeks. But what I do want to talk about are some of the side effects. And so the reason this drug, you don't see it used quite as often, is because it really has profound CNS depressant activity. Sometimes it's actually worsened with other drugs, and so you can also see dependence liability, so they are habit forming, and they do offer biotransformation induction, and so they're problematic, lots of side effects. This is in contrast to benzodiazepines, and so in the 1960s, they used to, when they first made this drug, they marketed it as mother's little helper, and so for the women who were dealing with rambunctious kids and problematic husbands, they would take these benzodiazepines and basically just kind of reduce anxiety throughout the day. And so the Rolling Stones actually had a record label called Mother's Little Helper. I think this was in the 1970s. This was before my time, so I don't know the exact date, but I do know that they did make that song about that. A little bit of history. And so what we're really dealing with is kind of central to GABA. And so remember, this is the GABA receptor, and there's different binding sites. And so this is looking at it from a cross-sectional standpoint. Understand that when GABA is active or open, these chloride channels can kind of flow in. Within the GABA receptor, we've got a binding site that binds to the endogenous neurotransmitter, which is GABA, but we've also got a benzodiazepine binding site and a few others as well, which I'll show you what these look like in the next orientation. So this is looking down at the receptor. So these are the subunits. Here's the chloride pore. Here's where GABA binds, and then here's where the benzodiazepine binds. And it's unique in the fact that well, one, GABA is the main inhibitory neurotransmitter. GABA is found throughout the brain. And what these benzodiazepines do is they kind of potentiate or enhance the function of GABA. And so what they do is they increase the affinity of the neurotransmitter for that channel. And so what happens is that you see an increased frequency of the channel opening. But the key here is that in order for this drug to work, GABA, the endogenous neurotransmitter, must be present. Okay, and so these are right now we're going to talk about them in the context of anti-anxiety, anti-epilepsy, but we're also going to look at them in a future case for controlling anxiety. And they do have side effects, but these actually are pretty moderate compared to some of the other side effects that we've been talking about with some of these epileptic drugs. And so we'll come back to the benzodiazepines again and again throughout the next couple weeks. Benzodiazepines include diazepam, clonazepam, and a few other ones. For some of these patients that have really profound seizures, you can give this drug rectally, or you can administer it IV. And basically, what happens here is that the GABA channel is open, chloride flows in, the cell becomes hyperpolarized, it becomes inhibited, and then there's a reduction in the likelihood of a seizure propagating or a focus reoccurring. Limitations to this drug, however, include profound sedation, as well as a little bit of a tolerance, which is indicated by the seizure just not responding well over time. Here's a list of drugs that are clinically relevant, but are probably not going to make it into the STEP exam because they're relatively new. Some of them are under various clinical trials. Some of them are only found in Europe or Canada. But just as you kind of go through the literature, and I'm sure some of these drugs in the next 12 to 15 months will get FDA approval if they haven't gotten it already. But I'm not going to test you on them, but just so you know, and so you've at least seen them once, this is where some of these drugs are coming from. In terms of therapy, things to consider for these drugs is the duration of therapy. Typically, we like to see patients be on these drugs for 2 years and be basically seizure-free for those 2 years. 80% of the patients that do have a seizure recurrence will have a reoccurrence within the first 4 months of stopping therapy. Other things to consider is the type of seizure. Obviously, certain drugs are indicated for certain seizures. There's social factors to consider. Many of these drugs are sedation provoking, and obviously, if the patient had a seizure, they're going to have driving privileges revoked. The medication side effect profile, some of these drugs, again, are quite nasty. And we didn't even touch on special populations. We didn't talk about controlling the seizures in infants or children or pregnant women. But it does kind of beg the question, there are special topics in toxicology that come about because of this. We had briefly touched on some of the drugs that are teratogenic. We didn't talk about overdose or withdrawal. We'll table some of those discussions for some of the further cases coming along in the BBC block as we go into psychiatry, because benzodiazepines are kind of like the steroids for psychiatry. You basically throw benzodiazepine at, I would say, probably half of the cases that we're going to talk about. It's kind of the ongoing joke with psychiatry. You know, as often as we use steroids for pretty much any inflammatory event and any type of disease, you can see benzos being used quite readily. And also, there are some suicidal thoughts that can occur with some of these drugs, which again, we'll table for psychiatry. So that's it for epilepsy. I'm sorry I sound horrible. I'm getting sick, and I needed to get this lecture out before I completely lose my voice. But if there's any questions, please email me, and we'll talk about some of these drugs, excuse me, in the case. Thank you.